Hi, my name is Lawrence Ong. I'm an internal medicine resident over at Dulce Medical Center in Austin, Texas, and I'm here to present a case to you about Hodgkin's lymphoma presenting with a paraneoplastic cerebellar degeneration syndrome. So our case begins with a 31-year-old African-American man with no known past medical history. He presented to the emergency department with gait instability, confusion, slurred speech, and a non-focal headache. Of note, in the past 6 months, he had also had unintentional weight loss, fatigue, joint pain, and night sweats. On physical exam, he has supraclavicular lymphadenopathy bilaterally. His neurologic exam was otherwise non-focal. He was able to follow some commands and answer some questions appropriately. His vitals were within normal limits. His lab work was not very remarkable for anything acute. His imaging, however, CT chest, abdomen, and pelvis revealed an extensive mediastinal, hilar, and parapancreatic lymphadenopathy. All these findings were concerning for lymphoma. Interestingly, the MRI brain also revealed enhancement of the cerebral and cerebellar sulci, as well as a subtle enhancement within the white matter of the cerebral hemispheres. We had more biopsies, and a supraclavicular lymph node biopsy showed CD30 large B cells consistent with Hodgkin's lymphoma. Bone marrow biopsy revealed no evidence for involvement of Hodgkin's lymphoma. The LP showed pleocytosis with lymphocyte predominance. CSF cytology and flow cytometry were negative, suggesting a reactive lymphocytosis. So the patient was started on oral dexamethasone, and his headache, confusion, slurred speech, and gait disturbance improved. The patient was also started on ABVD chemotherapy for his Hodgkin's lymphoma and was discharged home with close follow-up, and he was close to his neurologic baseline. So given his pleocytosis on his LP with a negative CSF cytology and flow cytometry, we think the patient had a cerebellar degeneration syndrome. This is a paraneoplastic syndrome that can be caused by Hodgkin's lymphoma. We consider the differential of leptomeningeal carcinomatosis, given the cerebral enhancement on the MRI, but this is a much rarer finding in Hodgkin's lymphoma with a 0.1% incidence, and unlikely with his LP results. He didn't have a positive flow cytometry or cytology in his CSF. So our learning objectives, we will describe and define paraneoplastic neurologic syndromes. We will understand the diagnosis of paraneoplastic neurologic syndromes, and we'll understand the treatment and prognostic implications of a paraneoplastic neurologic syndrome. So paraneoplastic neurologic syndromes are disorders that can cause morbidity and mortality and coincide with the malignancy. They are not due to direct tumor involvement or metastatic spread. Paraneoplastic syndromes that involve the CNS are rare. They are present in only about 1% of all malignancies. A cerebellar degeneration syndrome is the most common paraneoplastic neurologic syndrome in Hodgkin's lymphoma. The classical symptoms include confusion, headache, gait ataxia, and dysmetria. The diagnosis can be made without further testing if the patient has classic symptoms and a confirmed tumor. However, if the clinical picture is unclear, one can order an anti-TR and anti-Purkinje antibodies. Treating the underlying tumor usually resolves the symptoms. However, neurologic damage is possibly irreversible despite treating the tumor. So paraneoplastic neurologic syndromes are an important, rare, and overlooked cause of altered mental status, especially in patients with a history of malignancy. Morbidity is not caused by direct tumor involvement or metastasis. Treating the underlying condition often resolves the symptoms. However, there can be potentially lasting irreversible neurologic damage. These are the references.